welcome to the Value-Based Healthcast. I'm Nick Wilkinson, a paediatrician who has an interest in setting up integrated care services.
And I'm David Hanna, another paediatrician. I work in Cardiff, and as well as my day job, which is a consultant in paediatric emergency medicine, got a really interest in value and sustainability.
And so this is the Value-Based Healthcast, where we're exploring the development of new services that sort of improve access to the whole population, improve outcomes, and with minimal additional resource. So we're delighted that we've got two of our colleagues here, Preetam and Prash. But before we introduce them, how was your summer?
It was full on. Yeah, we went back to Ireland for 10 days with the family, so that was nice. Back to my roots. And we came back to Wales and spent a week on the Garreg Peninsula in Storm Lillian.
More of your roots.
Pegging down tents at 3 a.m. So that was quite full on. So the kids back in school now and back in work. So how about you?
Oh yeah, so I got very familiar with the Olympic Games, and particularly with the climbing. Because I was post-op, I got experience of healthcare from the other side, and I have to say, it was amazing. I had eye surgery, and it was very slick, very thorough, and kind of relevant to today's talk, which is good.
Yeah, I'm really looking forward to today. So before we introduce our guests, what I'm going to do is just outline the format of the Value-Based Healthcast. So as Nick says, this is an opportunity for us to meet and learn from colleagues across NHS, often Wales, but not always, about interesting innovations in value and sustainability across the patch. And sometimes our guests have been fellow doctors, but actually more often than not, they've been other members of the multi-professional team. So we're going to hear shortly from our two guests. The format's going to be, there's going to be a presentation followed by some questions and answers from Nick and I. We would really love to hear from guests in the audience. You can use the Q&A or the chat function to ask questions of our guests. And what we'll do is Nick and I will look at those throughout the Healthcast. And if we see any which are particularly relevant at that point, we may jump in and ask them, or we may wait to the end to do that. We'll aim to wrap up shortly before 3 o'clock, but really, we would encourage everybody to jump in with questions, and we'll put them to our guests.
So it's nice to be into the realm of musculoskeletal here, and so first off, I was just going to introduce Preetam Kodamuri, who is a consultant trauma and orthopedic surgeon at Wrexham Maylor Hospital, where he's been there for 5 years. He's had the distinction of being awarded the British and European Hand Surgery Diploma, and he's widely travelled, obviously picking up a lot of experience and sharing experience internationally, including units in the States and in India. So he's been heavily involved since in Wrexham in research and development and for service improvement, along with Prash.
Thanks, Nick. And I'd like to introduce Prash. So Prash Jesudason is a consultant hand and orthopedic surgeon, and Prash works in Ysbyty Gwynedd as well. So following training in Manchester and Lancashire, Prash joined Ysbyty Gwynedd around 2012. And alongside Preetam, he's been involved in research and service improvement around sustainable healthcare. They've had quite a bit of acclaim, I think, nationally and internationally around developing and designing pathways to reduce waste, particularly around surgery. And their main focus is obviously on reducing carbon footprint of surgical interventions and improving productivity. So I think without any further delay, we'll hand it over to Prash and Preetam.
Thank you very much, everyone, and thank you for the introductions. It's it is humbling, really, to be on this platform to share our experiences and to be able to reflect on what our journey has been for the last several years. Prash and I have had humble beginnings pre-COVID, and it's a great honor to be presenting what we've done over the last few years. Prash, do you want to come in before we do the talk?
Yeah, just to echo that, really deeply honoured to be on this platform with you and share some of the what we think are quite cool things we've done over the last couple of years. So, Preetham, if you go through the format, and then I'll pick up.
Brilliant. Okay. Can we have the next slide, please? Next slide, please.
Sorry, guys, just trying to get to the next slide at the moment. Apologies for the lag. We're doing the old classic speaker in one end of the country, slides in the other end of the country today. So
Indeed. You know what? Well, the first slide would have described what the journey has been, and it was going to tell you that this went back to pre-COVID when I started my journey as a new consultant, and Prash has been at Bitsa Gwinnett in a neighboring hospital, and we were really curtailed in what we could deliver for planned care. Just go one slide up for us, please, Gary. So the planned care was really difficult to deliver during the COVID for obvious reasons. So we were looking for ways of how could we work differently in the amount of opportunities or the resources we had. So back in 2019, 2021, we kind of went through the conceptualization of the project at how do we go around looking at how can we deliver hand surgery within our remit. And there was a lot of clunkiness that we saw and felt during the patient pathways as well. So we also tried to see whether we could improve the patient pathway and the patient journeys as well. That was the first couple of years. And the next couple of years was essentially starting with the project and having the help from national bodies like the Center for Sustainable Healthcare. And this project was enrolled onto the Green Surgery Challenge. And that really put wheels on the project. And we had help from the Bevan Commission, the Welsh think tank group. And then it kind of rolled on into most of its current format of we've had a few publications out of it. We've been fortunate to present it locally, nationally, and elsewhere. Been fortunate to have a high degree awarded for it. And we're now expanding within our field of orthopedics into other specialties like trauma surgery and arthroplasty. Can we have the next slide, please? Fantastic, thanks. And we're just doing our best to get the next slide up. Can I ask a little bit about the root of the project? So was it the two of you in a dark room imagining the future, or what was the catalyst?
Well, kind of. Well, Preetham and I, we were trained by the same people in our fellowship, and we met on the sort of conference circuits and became dear friends. Okay. And we kind of had this same idea at the same time, that we're both interested in sustainability, and as surgeons, we're a bit late to this party. Sustainable healthcare is not new; it's been around for a long time, and our colleagues in anesthetics and in primary care and various other places have really made quite enormous changes over the last few years. And as surgeons, we thought, well, it's time for us to do our part, and we came up with the idea at the same time, round about just before this Green Surgery Challenge was brought out. So this was a joint venture by the Royal College of Surgeons of England and Edinburgh and the Centre for Sustainable Healthcare. And they basically threw down the gauntlet to all surgical teams in the UK, basically saying, can you reduce the carbon footprint of your activity and demonstrate change within, was it 10 weeks, 10 or 12 weeks? I can't quite remember, but within a very short time frame. And so we established this project, set it up, and within 10 weeks delivered an 80% or so reduction 85% reduction in carbon footprint of a carpal tunnel operation by just making 3 or 4 small, simple changes. And then this whole thing snowballed from there, really. And it's gone on forwards. And obviously, Preetham will share with you the data in a little while. But from that Green Surgery Challenge and from those initial conversations, the project has evolved now.
I'm fascinated by that sort of time frame, because in our experience, as I'm sure you're the same, when your backs are against the wall, for example, in COVID, suddenly we found ways to do video consultations. And we talk about with our trainees, we say smart objectives, so measurable with a time frame on them. And I'm really interested by that. So there was a 10-week window, and you had to just get stuck in and try and make it happen. Can you tell us a little bit about that? Because that blows out of the water so much of the long-term planning that goes into making the smallest changes sometimes.
Yeah, indeed. Well, I mean, we had a bit of run up to it. It wasn't just 10 weeks and then you have to do it. So we had a few months of planning and getting ready before the Green Surgery Challenge happened. And then basically Preetham and I sat down together and basically brainstormed, where are the waste hotspots in this operation? How can we do this more efficiently, more effectively, with less stuff, but not compromise on patient safety? Preetham, do you want to come in there and
Indeed,
add?
yeah. So a lot of groundwork was kind of made leading up to the Green Surgery Challenge. I still remember one of the British Orthopaedic Association leadership alumni web groups shared the link of the Green Surgery Challenge, and it said, I was already in discussion with a few people about the sustainable agenda, and so they said this is right up what you're looking for. You should really enroll your project into that. So that the project that we were talking about was kind of already in its infancy before the surgery challenge came on board. And to be honest, I think of the 6 or so projects that were shortlisted, 1 or 2 people dropped out because they couldn't deliver there. It's not always possible, but there was a bit of groundwork that we had done beforehand, and just we were fortunate to have 1 or 2 key people who shared our vision and said, yeah, this is a great way of doing it. And you just need to find that 1 person or 2 people who kind of can understand where you're coming from, and then help you to take it further.
Okay, and so just so again, we've just really so.
Sorry, you guys are yeah.
Just let us know which slide you want. So we're on the 3rd slide there, I think. So our apologies for this.
That's all right. So if you can go to the next slide where it says conceptualization. We did talk about this just now.
Yes.
Yeah. So if you can move on to the next one.
Brilliant.
And this again says that this is a separately thought out, but almost similar thought process that happened between the 2 units. And this is where we looked at where do we start really? What are the avenues that we can look at? I went around my local hospital looking for, well, if I want to deliver care slightly differently, is there a physical space where I can deliver that care? Because a lot of care was being, you couldn't go and open up a room in a clinic because it was, no go. It was not a green zone for COVID at the time. And how do you actually get the patient in through the hospital and out of the hospital in a safe, contained green zone? So we had to look, think about a lot of that process. So we were going through a lot of that during that phase. So just move on to the next slide after this next one.
Thanks.
And then another slide, please. So this kind of went on until 2021, 2022, where we were chatting with our local managers and saying we want to, deliver this care value in a better way. As expected, there was a lot of resistance from the local managers and saying, how can we do this? So the BSSH, which is our British Society for Hand Surgery, published guidelines back in May 2022. So we're almost a year down the line, where they've said these are the guidelines that you can operate outside main theaters, and these procedures and these certain number of people you are required. So this was a major shot in the arm for us. We could take this to our managers and say, look, now there are national guidelines that you can look and follow. And then that really helped us in improving. We both were in the process of writing up local guidelines, and there were SOPs, standards of operative, practices, which we were developing just before these guidelines came out. But this coming out around when we did was definitely helpful for this project. Next slide, please. Prash, do you want to come in?
Yeah, absolutely. So just taking a little step back, one thing we didn't mention is the Green Surgery Challenge was not operating outside of theatres. So the Green Surgery Challenge was changing an operation to reduce the carbon footprint. So Preetham will come on to exactly what we did in the theatre. So there's two basic steps we've done. The first thing is really maximize and reduce the amount of waste that we're generating in the theatre. And the second stage was actually moving the whole damn thing out of theatre and doing it in an outpatient setting. So we've now done both of those two things. And the way we did it really is by building an effective team. So these are all the stakeholders involved in all of this. It's not just the two surgeons thinking about what they want to do and telling everyone else what they want to do, but actually engaging with all these staff. And the reason it worked so well is that we had people from all of these little bubbles to help us along the way. And it's this collaboration was extremely important. And this would not have been successful without, for example, patient support and the theatre practitioner support, and the sterile services unit team were really instrumental. Infection prevention, everybody, and obviously the support of the local hospital management team. Next slide, please. And this is just a snapshot. This is not everybody involved, but these are some of the main people involved in the project, and across the two sites. Do you want to name everyone? Too many people to name, isn't there, Preetham, really?
Yeah, exactly. There are just a few people, There are far too many people that we can't include on one slide, and they've worked tirelessly behind the scenes, whether it be, setting up guidelines, whether it be, those meetings with the managers, whether it be something not working in terms of infection control guidelines. So, lots of work, for you to do something small and simple, even though it makes sense to you, it has to be changed. So yeah, there are lots of people involved. Yeah.
Okay, next slide, please. So the first part of the project was really simple. Is can we reduce the carbon footprint of a carpal tunnel release? So carpal tunnel syndrome is a really super common condition where patients describe pins and needles, numbness, clumsiness, discomfort in the hand. And it's the commonest operation we do in hand surgery, and orthopedic surgery in total is the commonest operation. And basically, we picked three things to deal with, really. One is reduce the volume of instruments that we're opening in the theatre. And that was really quite key. So we're lean green setup. So not opening a load of instruments just in case we might need that bit of kit or that bit of kit, just actually honing down on what are the key bits of kit that we need to do this operation safely. And that was part one. The second part then was actually reducing the size of the drapes that we were using. And also the other point with the instruments is the instruments come on big trays, and we massively shrunk down the size of the trays. So when they go off in the autoclave, they take up less space in the autoclave, and it can be stacked more effectively and efficiently. And also it takes less time to process and count and clean the instruments. So there's lots of little savings going into that. And then the phase two really was to develop an actual lean green patient pathway as a whole. Next slide, please. So on the left is our green set, and on the right is the standard set in Wrexham. And you can see immediately there's half the volume of instruments required. And if you go to the next slide, please. And even the standard sets, we only have about half, in my hospital, I have half a dozen standard sets. And if I do 10 or 12 of these procedures in a day, we run out of standard sets. We have to open an orthopedic handset, which has a plethora of instruments I'll never use for this operation. So if you compare the standard model to the lean green model, it's absolutely bonkers how much kit we've saved really there. Okay, next slide, please. And also the size of the drapes. This is how we've done carpal tunnel decompressions for years, with these huge drapes that cover the patient face to toe. And now we have just two small drapes covering the actual operative site, which is relatively small. Next slide, please. And remember, all of these drapes get chucked in an orange bin for incineration. And just in one case, in average, we were throwing away about 3.5 kilos of incineratable waste. And this is just within our first few lists. We've halved that. And next slide, please. And actually, that waste has come down even more now, probably by at least another 50%. And that gives us an idea there of our first few cases there. Next slide, please. And these are the carbon footprint savings, which are really quite. Sorry, go back one. Forgive me. And when we look at the standard setup, we can reduce the carbon footprint by 22 kilos per case, which is an 80% saving of the carbon footprint. And most of it is actually due to the instruments. So having smaller instruments and smaller drapes makes an enormous difference. We're burning less stuff, and we're using less resource and energy to clean and process the instruments. You want to add anything, Preetham? Please feel free to chip in.
No, all good. Thank you. Yeah.
Okay, next slide, thanks. And then we did an economic analysis, and we read pretty modest savings as well. Because we're burning less stuff, we're opening less stuff, we're using less equipment, we're using less energy to process it. And so we've got 65% savings. Now, remember, this is all data from the theatre itself. So this is before we've even moved out into the outpatient setting. So we've made pretty big savings just within the theatre itself. Next slide, please. So our results following our lean green hand surgery lists, we had about 300 patients across the 2 sites, and it's now the standard of care. As of date, we've had no known complications. We've had no surgical site infections that we're aware of, and we've had excellent, overwhelming patient feedback and overwhelming staff feedback as well. So now that we've moved into the outpatient setting for this, I've had some patients say they can't believe this operation used to be done in theatres. And we've had a few patients that had one side done the old way and one side done the new way, and all of them are much happier with the new method of delivering this care. Next slide, please. Do you want to take over here, Preetham?
Indeed. So this next phase, because we were so happy with the results of the first phase, where just 2 small changes were such a massive impact on the outcome, we said, can we now move this procedure outside the theatre? So we just looked as a pilot to look at the pathways of cost of each patient coming into the clinic, and each time they get reviewed in the clinic, and then they go to the theatre, ward admission, and then getting discharged from the ward, and then further follow-ups. So we just stacked them all up, and each patient costed about £1,800 from beginning when they come to the hospital to when we discharge them. We then exactly did the same thing for patients who were then had the operation outside the theatre and then were given virtual follow-ups. So that cost came down dramatically to £680. So you could potentially save £1,120 per patient, and equate this to about 80,000 carpal tunnels, which are done in the UK. If you were to just do these procedures outside the theatre, that's a massive amount of savings. Next slide, please. So we then opened up 2 minor procedures rooms in Wrexham and Llandudno in North Wales. We now have been performing these procedures since last year, June. And we've been very happy so far, because patients, as Prash alluded to, are very happy that they don't have to wait for almost half a day for a 10-15 minute procedure. Because what would previously happen with patient would be then coming to a ward for an operation, and they might wait for almost half a day for a 10-minute procedure. Now it's almost like going to a dentist, where they get an allocated 1-hour slot where they come in, and then they get seen, get admitted by the nurses, have the procedure, and then maybe have a cup of tea for half an hour, and then they go home. Because it's a local anesthesia procedure, patients are mobile, they're up and about, they're walking, they don't need any transfer through the porter. So next slide, please. What we then found is the time required for each patient from beginning to end of the carpal tunnel was 4.5 hours in a traditional pathway, and it came down to about 2 hours, almost at the maximum for each patient. And the number of people required to support the patient, whether it be the staff in the theatre, the porters, and the ward staff, dramatically came down from about 9 to about 4 people. And that includes the training registrar, that includes the scrub nurse, that includes the surgeon, and the admitting nurse. So there have been days where I've done this procedure list on my own, and there are only 3 people supporting each patient, and there have been fortunately no problems so far. Next slide, please. So we've done these procedures across the 2 units now, almost 100 patients. Again, we've not had any complications, incredible patient satisfaction. So we collect the feedback from each patient at the end of it because we're really interested in the outcomes. We then give them a phone call about 6 weeks to make sure that they're doing okay, 2 weeks for their wound reviews, either in the community or to come and see us, whichever is easier for them. And we found that because we are doing this regularly, we have reduced our waiting times from when we say we list them to when we operate on them dramatically. And because we're creating more space now in the theaters where they were being done in the theaters, now they're outside in being done in the outpatients. That theater space is being utilized for bigger operation procedures like hip replacements, knee replacements, or maybe bigger trauma cases. About 50 extra operating cases have been done because of moving them out into the outpatients. So they increase productivity as well. Next slide, please. So there are multiple themes which are advantageous. So staff can be employed to do other things. Patients don't need to come so often to the clinic. There are about 80 to 90% of carbon dioxide savings. There's 2/3 less clinical waste, 2/3 cheaper if you were to do them in a theater and outpatients. And patients love it. Patients have universally very happy outcomes. Next patient. Sorry, next slide, please. So essentially, sustainable triple bottom line is if it's great for the environment, great for the patient, and great for the pocket. This project kind of fulfills all these 3 criteria. Next slide, please. So a value-based healthcare, true value is sustainability is if you're delivering really good outcomes with less impact for the environment, social health, and financial health. So this project decreases the financial impact, decreases the environmental impact, and increases the outcomes of the patients, if not equal, if they were to be done in the theater. Next slide, please. Raj, do you want to come in?
Yeah. I'll just come back to that point. That's a really, really important point because it's very rare that all of those 3 in that Venn diagram, all of those 3 things link together, that it's cheaper, it's better for the patient, it's better for the society, it's better for the environment. Everything seems to link in this project. So with this project, we're right in that sweet spot in the middle, which is really huge. So regional impact. There have been green groups in Wales. In fact, Wales has pioneered green groups in hospitals. And we have a very active green group in Bangor and Wrexham, and then a pan-Wales NHS green group. And this has morphed into other projects as well. So we're really looking heavily at trying to eliminate single-use plastic wherever we can. And green theatre practices have now become the norm. We're still not as good as we should be, but the Royal College of Surgeons have brought out a green theatre checklist, which has about 20 points on it of ways that we can make our theatres run a bit more sustainably. And these are just a few ideas that we've been doing now quite routinely, like improving the segregation of waste and making sure that the recyclables are definitely put where they need to be and not everything's chucked in the orange bin for incineration. And also reduce the procurement of instruments that we need. So just that mindset of just having things open just in case we might have to need them, whereas it might take 10 seconds for that bit of kit to be opened. And it's just having that mindset that we change the way we practice. And the key really, where this is quite exciting, is expanding this into other day surgery cases. So ophthalmology, ENT, dermatology and plastics are all key examples of this. Now, many units are already doing this and moving these cases into outpatient-based settings. But I think there is a lot more we can do, a lot more. And that's really exciting, not just delivering it within our own subspecialty of hand surgery, but then extending it into orthopedic surgery in general and then into other surgical subspecialties. Next slide, please. So national impact. So back in 2021, we were runners-up in the Green Surgery Challenge. Unfortunately, we got pipped at the post by some guys from Leeds, but we were still very proud of that. And then Preetham and I have been working very closely with the Bevan Commission, who've been supporting this work, and they've been instrumental in helping us deliver it as well. And they very kindly gave us an innovation award, the Sir Mansell Hayward Innovation Award, which was presented to us by Mark Drakeford just a few months ago. And next slide, please. And this is where I'll big up Preetham a little bit. He's a very modest guy, but Preetham's used this work as part of a higher degree, a master's in hand surgery, which very few people in the UK have. And his dissertation was on this quality improvement process in how do we reduce the carbon footprint of carpal tunnel surgery. And this was passed with merit. Next slide, please. And then we've had a few publications on this. The major publication was in the European Journal of Hand Surgery, and this won the top 10 best papers in the journal for last year, for 2023. And we were able to present that on a number of occasions at very major international meetings. Next slide, please. So, Preetham, do you want to come back in here?
Of course, yeah. So we are now in discussions with the Bevan Commission on how can we adopt and spread this practice across Wales. And just small changes within the theatre can have major impacts all across. And I think that is something that universally, this is easily reproducible. And that's the major attraction of this project. And if you want to move out of the theatres, there is enough support out there now to kind of support that practice. And, we always say we're more than happy to support, anyone who's interested in like-mindedness. Just small changes can deliver big impacts. The point of this project is not only just to save money, or not only because it's environmentally great, but we both believe that it is the better way of delivering service to the patients. And I've not yet had a patient who said, I wish I had my operation in the theatre rather than this way. And it has multiple advantages, wherein multiple hospitals have winter-bed pressures, and you're not relying on resources where staff might be taken off to do other things. So there are multiple advantages to this project, and we are more than happy for this to be taken up if anybody is interested in taking it forward in their local community or local hospital. Next slide, please. So as Prash alluded to, we are interested in taking this further within our hospitals. We are now published a paper on how can we, because what we're really looking at is we are literally scratching the surface of the iceberg, really. As within orthopedics, we are huge contributors to carbon footprints with all the implants and the amount of waste we deliver. For example, a carpal tunnel release might release about 80% of CO2 emissions, but a hip replacement releases about 100 to 200 to 300. So it's more than double the amount of it. So if we can really get our hip and knee colleagues to buy into this and look at their practices and say, how can they, decrease their carbon footprint. So we've looked at what's the carbon footprint of a total hip and arthroplasty inside a UK hospital setting, which recently been published. So that's the first step in the right direction, and then push on and say, how can you reduce that? And both Prash and I have kind of taken on this work with the help from the Bevan Commission. We both enrolled into a 2-year fellowship where there is more support that we are getting in further improving our this project and enhancing and broadening our scope on it. So we are very excited and with the opportunities that are out there. We just feel that the work that we've done is just the beginning of a journey.
Wow, that's really amazing, guys. That's a fantastic presentation. And you talked about the benefits there for patients in costs and sustainability. But one of the benefits that come across is how energized you come across. In this age where we're all just a little bit, wilting. There's bad news the whole time. So just the energy, and you made that slip where you said, next patient, please. And I tell you, it doesn't surprise me. I think you're getting through the patients that quickly. So, as you were with the slides. So brilliant presentation. And I loved your use of data, including the graphics, of just comparing the size of waste, because it really does bring it home exactly what you've managed to achieve. So it was just, how did you keep other people's motivations on this? Because it's so easy for these sort of projects just to slip. How did you manage to do that?
I think being motivated, I just go back to thinking, why did I start this project in the first place? And if I feel that there is a desire within me which motivated me, and it is not difficult then to motivate others. And I always find that if that reason of why you do something lies outside you, then there is a good chance that that project might burn out. If it is within you, as in the reason of doing something is because you're interested in it or because you firmly believe that that's the right thing to do, then you're always thinking of how can I convert this challenge or this hurdle, how can I tackle that, or how can I make this into a, convert that into a plus point. And to be really honest with you, I have been fortunate in my place where I have had one great theatre practitioner, one great manager who shared the vision, and one great person who works in the fracture clinic with me. They've all been instrumental, and you just go back to them and say when things don't work. I'll give you an example. When we were trying to move this outside the theaters into a small clinic area, we've converted a clinic room. We haven't really got a new place. It's a clinic room that we utilize as a minor procedures room, which doubles up. When it's not a minor procedures room, it's a clinic room. So the infection control people came and said, well, this is too small, you can't have it. And, this isn't, and they were essentially said, you have to stop. When then I literally remember going with a tape measure and measuring that room out and saying, look, the room that you're measuring, saying it's too small, isn't actually small with the guidelines that you're proposing to me. And you're saying you have to have a scrub sink installed. So there are lots of, red tape that you have to navigate through. And I remember that in our health board, we were both given an award for sustainability. It was about a couple of years ago for this project. And just the week after we were given the week before, actually, we were given the award. We were told you can't continue with this project because it's just not going ahead. You don't fulfill the tick boxes. That was super demoralizing for me and for Brash both, because it took us good 2.5 years to get to that stage, and then suddenly saying, well, some person sitting in an office saying, oh, this doesn't fulfill this criteria, is really frustrating. So but then how do you then work from it? Where do you go from there, right? So you have to go back to the drawing board again and then say, look, why did I want to do this in the first place? So then I went back and then collected all the patient data I had for all the information that I've been collecting. I compiled a big PDF file, and then I attached that, and I attached the national guidelines, and then I kind of bombarded them with all of this and said, look, all of this evidence is out there, and you tell me one reason why you're asking me to stop it. And again, we were fortunate from Bevan Commission, the Welsh government, and all of these people kind of were on our side a little bit, and they kind of helped for this project not to die a death.
So Preetham, I'm fascinated by that, and particularly the last bit where you've actually just won an award, and then the next minute somebody's saying you can't do it, and I just fascinated because often our experience is we have to fight 1,000 battles to get these things over the line. Very early in the session, you mentioned that there was some resistance from local managers maybe at the early stages of the project. Could you tell us a little bit more about that and how you navigated that particular challenge?
Raj, do you want to come in, or do you want me to take the question?
Yeah, because I've had a lot of problems as well, same problems. I think the reason we got all this through is basically a combination of tenacity and also trying to be sincere, not getting too upset about it. Just constantly chipping away at the coalface, and eventually something will give, which is exactly what happened. And also we said, look, we're too far into this project for you to shelve it. And also the data speaks volumes for itself. So
and that fascinates me, because I'm interested just to learn what the face of that resistance was, because Nick and I both work in Cardiff and Vale. The headline is at the moment that the Health Board's in budgetary deficit of £43 million. So everything we do is being scrutinised. So it's difficult to imagine a situation where you've got a bit of work which will liberate genuine savings, but there's problems getting everybody on board. So how did that manifest itself?
I think it was a bit of fear, if I'm honest, and trepidation. Like, hold on, this can't be right. You're telling me you're going from 9 members of staff to 4 members of staff. You're going to do more with less, deliver more. It's going to be cheaper, better for the environment, and you're going to get more cases done. And we said, yes, we are. Yes, you got it. So people I don't think they really understood how serious it was. And once they actually understood it, and we actually delivered them the figures and said what we can actually achieve, then people started to take notice. But there were the conventional barriers, and we're fighting against decades of dogma that these are serious, big operations that have to be done in clean, ultra clean area theatres. But the evidence is there that the infection rate we don't need anything other than natural ventilation in a procedure room. So the guidelines from 2022 did help us a lot.
Yeah, exactly that. So when we were setting up this room outside the theatres, the one single major obstacle was saying, oh, you don't have any ventilation unit, you need to have air changes. It's like a theatre environment, because the Welsh sterilization criteria was different to what English was or England was. And then it was a constant battle, and that's was one of the things where saying you can't do it, you can't do it, you can't do it. And when the national guidelines came out saying these are the things that can be done, safely outside the theater, then we could just say, look, these are the national guidelines now. You got to now listen to these, and it's safe. It's absolutely perfectly safe. And it's difficult because the evidence that's out there is miles ahead. And such as in the US, there is a person who's been doing it for the last 15 years, 20 years, and you just you can't then say, well, so and so has done it, but they won't. It becomes difficult then to.
But based on the insurance model, it's not surprising that the US are early uptakers because cost is absolutely everything. Mm-hmm. But you've described really well there the change model, where you had the early success and then it plummeted off a cliff before you then recouped and brought everybody up. Where on the change curve do you think, because we got a question here from Anne Core about how has this been adopted then sort of across Wales. So where do you think we are in translating your work then through other trusts?
Very, very early still, very early. We haven't even fully adopted it in our own health board. So at the moment, it's just Preetham and I, and I've got another colleague about to come on board. But we're 9 hand surgeons in Betsy, and only 2 of us are doing this operation completely in the outpatient setting. Now, interestingly, we had our hand MDT meeting just a few days ago, and I think we've convinced our other colleagues that this is the way it should be done. So I think within the next 12 months, most of our carpal tunnels will be done in this way locally within our health board. Within Wales itself, I'm not sure anyone else doing this kind of setup. There are people operating out of smaller theatres, and but it's still set up like theatre operating lists rather than outpatient lists. Correct me if I'm wrong, Preetham, but I'm not aware of anybody else. Swansea have done quite a lot of work on this.
Yeah, I agree. So the work that we've done inside the theatre, the phase 1's been published. So people are really interested and they've taken on board. And I don't know, I yet to see somebody who's actually implemented the day-to-day clinical practice outside in Wales, outside the theatres in Wales. But I suspect what will happen is once we have more data available for our own practice, and we publish that outside the theatre as a phase 2 data, then that will be much more clear for people to say, look, it can be safely done, because there is the dogma, as Prash says, people are really concerned about infection. They don't want an infection. And out of the 1,000 patients, if one patient gets infected, they'll be like, yeah, this is screwed up. You can't do that
And
anymore.
of course, they will then undermine, even though that is not an outlier, because you still get infections elsewhere.
Correct.
And I have a vested interest in this because it's ironic, really. So earlier this week, I'm part of my job is rheumatology, and so I have to inject the joints of children. I have to do it in theatre because they're under 6, and we were talking about access to theatre space. And I sit in the theatre with 5 scrub nurses, and they don't need to be there, but they're there because that's the way things are done to able operational. And so I guess there's just one other quick question just to come back, and I know Dave's got some important questions. So are these real cost savings? Because we can talk about it, our individual list and the equipment we need, but actually things scaled across the hospital. So you still have to fit your instrument sets in amongst everybody else. So does it really make a saving? So is it real world savings you're talking about, or theoretical savings?
That's a complex problem to answer very simply, because the savings that you get in the NHS you don't see, obviously.
No.
Yeah. So that's the reason why I suspect if you're just looking at the trace and the instruments, they can be genuinely savings which are real world, not just for the procurement, sterilizations, and the time taken to count each instrument. There are lots of money savings in terms of, because time's money, energy is money, and the number of staff's money. So if you look at all of that, there is incredible savings just for that. But it is very difficult to kind of pull the information and say, look, this is how much a bigger instrument set would cost a unit versus a smaller instrument set. But it would be stacked up quicker, it would be counted quicker, it will be less people required, it will sterilize quicker. So in that way, you are generating savings, but we can't give you a tangible figure and say, this is how much amount of savings you're making. Yeah.
Yeah, brilliant.
Yeah, it's an interesting one, that, isn't it? Because then it sometimes feels a little bit like across an organization or a sector, you got to all be in it, or nobody benefits. If you do really good work in your part of the system, then the money doesn't fall out necessarily. So it'll get used somewhere else, but it needs everybody to have the full benefit. It needs the whole system to be looking in exactly the same way you are, rather than somebody else just going, oh, great, those hand guys, they're not using the Theatre 1 anymore. We can put another list in there and just continue on our merry way. So you're right, it is really complex, isn't it? And I'm really interested. So there's a guy in America, or maybe it's a lady in America, who has been doing this for 15 years. And so we've done it now in one part of Wales. How can we spread and scale this, anticipating, as Nick says, the change cycle and all the barriers that will be there? And I think that's often the stumbling block, I think, because somebody somewhere does something really innovative, but yet doesn't seem to get taken up across the wider patch. So how can you spread and scale this?
Well, it's kind of already happening, because we're not alone. I think we're probably the most vocal in Wales at trying to deliver this, and we're very passionate. Our care of the climate crisis we're in as well. This is where it all stemmed from. Is that we're doing our bit. We can look our grandkids in the eye and say we did our bit for the planet, not just in terms of recycling, but in terms of the way we come to work and everything else. And we haven't really discussed that enough. Obviously we're talking more from a value-based approach, but from a climate-based approach, it's really important. And that's where it's gained a lot of traction in the UK, is from the climate crisis. So there are pockets of people up and down the UK already doing this in procedure suites. It's already happening in the private sector as well, because obviously it's cheaper. They can get more done. They can improve their profit margins in the private sector for doing these kind of cases. So it's already happening, and nationally we're having conversations about this. Last year, Preetham and I presented to the British Orthopaedic Association, and it's the first time sustainability was the top priority of the British Orthopaedic Association. So the message has got out, but it's got out on the back of sustainability rather than the back of saving cash. So we're not alone. There are there are probably a dozen other units up and down the UK itself, sort of mirroring this. Whether they've done it in quite the same way we've done it, I'm not so sure.
Okay. And just going back again, reading your bio, Preetham, you've been to the Mayo Clinic, you've been to the USA, you've been to India. What's inspired you from the places you've visited that you've taken back to practice in the UK?
Yeah, in the Indian healthcare is something else, right? So the hand unit that I worked in, they probably would be able to deliver more value healthcare because they recycle everything. They recycle everything, including the water that gets given to the patient in the pot that it. So it's fascinating. When I went to the thing that was eye-opening for me when I went to the US was how streamlined the whole service was. And obviously they have a lot more funding in the healthcare than what we are able to deliver to our patients day in, day out. And I was fortunate to sit in and observe some practices of a couple of people who were delivering a lot of brachial plexus work. So there's really unwell patients, really disabled patients. In India, I saw a lot of trauma being delivered in a very pragmatic way. And, it's kind of two extremes. And, you have a very high-end spectrum, which is being delivered, which has got, probably there are no end for funding for them. And they've got on the other side, you have to do with what you have, but then they're delivering really premium care there as well. So it's great to see that, the value, both of them right high up there. So you don't, not just how much funding you have, it's how do you make it more applicable to each patient you see in front of you. That was the major thing I think I'd take from those two fellowships. If I just go back one question about the adopt and spread and scale question, we are in discussions with the Welsh government as well, who are interested in this work, and they are trying to push this agenda through the Bevan Commission of adopting and spreading this project across different health boards. So we are in the discussions of how can we support people who are interested in delivering similar projects.
Okay. And do you, sorry, Nick, do you have any people knocking on your door saying, I'm a hand surgeon somewhere, can I come and sit in or see what you do? Have you had those sort of requests yet?
To be honest with you, all the work we've done is like an open book. All the publications that we've done, they're full of pictures. It gives you the whole gamut, really. And I've had a few people who contacted me from the private healthcare in Birmingham saying, oh, we're really interested in do what you're doing. How can we do it? So I've spread my work far and wide. Every time I go to a national conference, when Prash and I would present these, we have people, contacting us from France saying, how can we make it work where we're working? So I think the major plus point for this work has been that we've been able to show these carbon footprint savings, and not a lot of work has been done in that view. So this is where people find it really interesting, because you actually can put a number on, say, like 80%, 90% reduction. That's what really attracts people.
Can I just say one more thing? If you do a list of 6 carpal tunnels, you have to plant 1 tree to offset the amount of carbon. So it just shows how carbon intensive a carpal tunnel operation is for the whole pathway. If we can reduce that by 80%, that's absolutely enormous. Notwithstanding the cash and everything else, and how
I think we should still plant the trees, though.
Oh, absolutely. Yeah.
So I think we're reaching toward the end now, and this, we just very quickly, we did just have one other question from Richard Baxter, and we value all the questions, and I think it was. So what volumes of carpal tunnel are required to maintain an efficient use of peripatetic surgeons? Have you done that? So how do you make your process then sustainable? So and scale it just within your confines. Have you thought about that?
If I say on my patch, we get about 1 referral a day for a carpal tunnel operation. So we get about 30 a month into the clinic. And the GPs here and the pathways are pretty robust, so a lot of those will end up having surgery. So I think we need to be delivering probably 20 to 25 a month. And And that's just to stay afloat. Now, remember, there's a massive backlog of these patients. So I think once we've cleared the backlog, even if we can have some sort of infrastructure that could deliver 30 patients a month,
Okay.
25 to 30 patients a month, that's probably what we'd need.
And I think a lot of what you're saying is, the enthusiasm, the knowledge, the depth that you understand. I think sometimes it probably needs, people like Cardiff and Vale and the managers to bring you down, just for them to walk it through in a space, so that you can create that visual approach, which helps the buy-in rather than just data, because data works a little bit, but I think the way you presented it has also been very engaging. I wondered if you had any last question.
Well, you put me on the spot now. I don't, because I've found the last hour fantastic. It just, for me, I'm always interested to learn about things I know nothing about, because medicine's so broad, but I'm really, really interested to learn about the how people have progressed the projects, the initiatives, the ideas they've had, because it's never straightforward. And I just really admire how both of you have managed to navigate the various obstacles that you've been presented with. You've used data, you've used conferences, you have pitched it in a different way to different audiences. You've got the financial, you've got the patient, you've got the green, which I think we need to do often. We have to pitch the same concept in many different ways. I was just really impressed and grateful for both of you to join us today.
No, I just wondered whether you had coaching from Dave Brailsford, because you've spoken to marginal gains really well, and I'm sure you'll run an effective sports team as well as hand surgery. You have encapsulated value incredibly well, and so from us, it's just trying to showcase the examples you're doing. This is an exemplar, so thank you very much for that. And yes, so we're so glad you came on, because we're now moved on into the summer and the autumn, and we hope to have further presentations. Was there anything that you would like to say just before we close?
I'd just like to say thank you so much for your time and your interest and your kind words. And it's always really nice to be able to show what we've done and how we did it. And it's, as you say, it's not a straightforward journey. It's still evolving, and we hope that we'll be able to share more things from our side in the next year or two.
Absolutely. Thank you so much for the opportunity. Been great. Really enjoyed it ourselves.
Thank you. Well, from Nick and I, thank you both. Thank you also to everybody who joined us in our audience. The next session we've got is on the 25th of October. And the team from the Wales Value and Health Centre will be in touch with everybody who is here today to keep you up to date and let you know what's in store.
Thank you.
Thanks, guys. Bye.